Someday I'll find home. The picture in my mind, a place where I can go, and you'll be always mine, always mine.
Okay. The topic of today is the role of ablation in HCC treatment. First of all, I'd like to thank Professor Luan and Professor Lu for this wonderful meeting in the really beautiful place in my life. Yesterday, faculty dinner, I was a little late, but we really enjoyed the wonderful place. And also, I'm very honored to be invited to this conference with a really special topics regarding HCC. So, as you can see, the program is really excellent. They all cover the whole section of HCC diagnosis and management. So, as many speakers already talked about, multidisciplinary approach is the really key word. So, shall we start? What is the role of ablation? As we know, we can divide the three categories of HCC treatment. First, local, second, regional, and third is systemic. However, depending on the availability, we can choose the proper options depending on the feasibility and expertise and patient population. These diagrams may show a broad spectrum. Local ablation is a representative method, and regional treatment is a PACE and PARV, and systemic, the recently immunotherapy. And also radiation therapy also is a very promising local treatment. As we all know, ablation is accepted as a curative option for early stage HCC in all HCC treatment guidelines. If you look at the BCRC guideline, ablation was finally survived as a curative treatment option for early stage HCC. So today, I'd like to focus on local treatment, that is ablation. We can divide this simply. First is a very small and very conspicuous and located at safe location. That is the first. The pretty easy case, but there are many more tumors that's larger than 3 centimeters, and inconspicuous on ultrasound, and located in dangerous location. That is the problem. For small, conspicuous, and safe location tumor, we can simply apply the single ablation using the radiofrequency or microwave ablation. However, for large and inconspicuous and located in dangerous location, we have so many options. So very difficult to decide. So there are so many options we have to combine. So which strategy is the best? This is a common question, but I would say there is no single answer. So depending on your situation, we can choose the proper option. There are so many ways to get into the center. What about the energy source? There are so many energy sources. At the moment, microwave ablation is a mainstay because this is a strong energy source showing the better tumor control. However, still, there is no proven survival benefit compared to radiofrequency ablation. That's why in Korea, still radiofrequency ablation should be dominant. There are many cohort studies on the randomized control trial. Any study did not prove the survival benefit of microwave ablation compared to RF. Fortunately, we have so many weapons at our disposal. So which energy is better? This is a long-standing question for 20 years, but there is no definitive answer so far, because there is no big difference in the survival. So I would say it is time to change how to use, like today. Today I like to more focus on best role from the basic. What is the basic? We already know, first, careful selection. Second, precise plan. Third, accurate and optimal ablation. And finally, post-ablation assessment. The strategic optimization is really important. Let me start with first, careful selection. This is the utmost important. We need to understand the pros and cons of any kind of local ablation technique. This is the first. I would say careful selection of the best candidate is the first door to successful ablation. Beyond just tumor location, we should consider many things regarding patient and tumor, as well as operators. So it will take time. That's why take your time for best result. Best candidate for local ablation is, as we all know well, the single smaller than 3 centimeter, well-defined, non-perivascular, non-subcapsular, and non-perihilar tumor. This is the best candidate for local ablation. So carefully select the enemy that you can definitely kill with a single shooting. This is a very important message. The key of the successful ablation is, as previous speakers mentioned, multidisciplinary approach. It's a really smart way to achieve best result. This is our center study. So multidisciplinary approach can improve the survival. Moving on to the second strategy is precise planning. I would say planning is the head for successful ablation. Without well-designed plan, we cannot build this kind of a gorgeous building. So please decide all the details in advance at planning phase. From approach, anesthesia, guidance, energy source, application parameters, and assistance technique, and finally, combined treatment with TACE or ethanol injection. There are so many things to decide before the procedure. Define the target ablation zone with optimal ablation margin, depending on the tumor size and microvascular invasion probability. And also, we have to expect the potential complication, immediate and delayed complication. According to the potential complication, we have to prepare to minimize this kind of complication. And also, please rehearsal any procedure in mind and refine the plan before the procedure, just one day before. And make a document on the detailed plan, not just in your brain. Precise planning is almost half of successful ablation. Moving on, accurate and optimal ablation. Always we have to try to make 10. It is time to move from just a bigger and faster ablation to more accurate and optimal ablation. Accurate placements of electrode is the most critical part for successful ablation. Punctual placement like sleeve watch. Flat minus procedure should be zero. That should be our goal. Everything is critical, even from the skin puncture side, can make different results. Choose the best electrode path for the best configuration and optimal ablation volume. Before starting your ablation, you have to ask yourself, is it accurately placed? Very simple question, but many times we forget. Are you sure? Please ask it 3 times. If your answer is clearly yes 3 times, at that time, start the generator button. This is really simple, but many procedures, many operators forget because Sony window must be getting worse just after the starting. Please remember. For accurate and safe ablation, there are so many assistant techniques, including fusion and contrast nasal ultrasound and artificial fluid. There are so many papers proven the efficacy of this assistant technique, fusion, CUS, and artificial fluid. So let me show our 2 cases using the fusion and CUS and artificial fluid, ascites and fluoride fusion. If the index tumor is inconspicuous or any potential for thermal injury, please consider to use fusion or CUS or artificial fluid or altogether. Okay, this is the first case, the single hepatic metastasis from simulated colon cancer. This is a preparation for artificial ascites in our site. We don't use just a spinal needle. We use the typical angiography introducer sheets, 5 French sheets, 18 inches needle and 5 French introducer sheets. So needle is very small and poor some window, so we cannot see clearly on normal respiration spaces. So needle cannot stay there. And go introducer, and then this is a simple trick. Please, okay. At the inspiration stage, you can insert the subcapsular portion. After that, after removal of the cell, and instruct the patient fully exploit. At that time, the sheath tip is located in the peritoneal space. After that, we insert guide wire, and then we can easily change the dilator. This is a very simple way compared to just using the spinal needle. Okay, and change the dilator. After that, we can infuse rapidly with the DW solution. And you can see after ascites accumulated as the right subbrain area, the liver is going down, and so is getting increased just in 2 to 3 minutes. Very cheap and quick procedure. And we can improve the Sony window like that, and we can approach more active ablation. Insertion using the microwave antenna. And you can see the very tiny 1 centimeter ectogenic tumor there, and diaphragm is liver is separated. That means that they can guarantee the safe ablation, no thermal injuries, that kind of thing. After that, we assign the tumor and tumor margin with the yellow line and the target ablation margin red line. So we have to wait ectogenic area approaching the red line. If you try this kind of things, we can make circumferential ablation margin. Just 5 minutes ablation compared to surgery, even laparoscopy surgery, I think there are a lot of advantages, especially liver function not so good. So really minimally invasive even compared to laparoscopic resection. So 3 MR and post CT. The second case is the artificial fluoride fusion. If the lesion is located in segment 7, artificial ascites cannot separate because there is a bare area. So in that case, we are using the artificial fluoride fusion as semi-erect position to minimize the amount of fluid. We use the 17 gauge epidural needle, approaching the CP angle, and you can see the artificial fluoride fusion. Lung is moving upward, and the Sony is much better after the ablation from the deeper portion of the tumor and then moving the superficial portion. There are 2 tumors. You can see on the left side, the ablation joint is quite successful. So there are so many ways using the artificial fluid. Please consider. Moving on the optimal ablation is also very important. Not just thicker, bigger we should avoid. Optimal is better than just excessive because of our poor living. Don't forget our poor livers. And also remember, HCC continuously recur until end of patient life. Finally, post-ablation imaging is also very important. Most operators just see the CT just 1 minute, but please take your time to evaluate post-ablation imaging. This is a really good opportunity to learn by yourself. Any complication and follow, re-ablate, you have to decide ablation margin, circumferential or eccentric, or any minimal potential complication is very important. And then, please take a seat and give your 10 minutes and ask such as 10 questions one by one. Placement of electrode was really accurate compared to your plan. Ablation zone is similar to your original plan. Was it excessive or insufficient? Why? Ablation margin, circumferential or eccentric? Or any mistake compared to your plan? Any unexpected event? Any complication? What did you miss at the planning phase or procedure? How will you do if you have the same patient with tumor? What is the lesson of your case? I know that every doctors are doing this kind of process, but if you feel the procedure looks easy, from time to time we forget. So compare your post-ablation results with the original plan first, and then find any difference, small difference between the both, and think about the reason why. What did I do wrong? Write down, please, what you have done well, and what you have done wrongly, and finally, what have you learned from this case? You repeat this process every day. For example, well done, please repeat the next case. Badly done, don't repeat anymore. Don't repeat same mistake. Finally, if you have a lesson, please share. Every wave of the ablation teaches you some lesson. Finally, basic forever. We are living in the immunotherapy. So there are so many studies are ongoing to emphasize the potential of immunoablation. But I would say we need more time, at least even 10 years. Okay? Maybe very small proportion of patients can benefit of combined treatment because ablation can increase the immune powers very low. So it's very hard to find who is the best selection. Many studies on immunoablation are ongoing, looking forward to seeing the promising results soon, but wait for a while. Don't forget the success of almost all procedures depend on the basis rather than the fancy novel technology. The basic includes, as we all know, careful selection, precise planning, acute and optimal ablation, and finally, careful post-ablation assessment. Novel technology is necessary for the best outcomes. Inclusion, fusion, EUS, artificial fluid, immunoablation, and even robotic assisted ablation. However, please remember, novel is useless if we miss the basic practice action. Okay, local ablation is the most minimally invasive and cost-effective treatment, and also showing the excellent outcomes compared to the surgical resection. So liver ablation now clearly living in the all treatment guidelines for early, very early in early stages. Now it is time to get to the deep position. So conclusion, very simple, you already know well, but from time to time we forget the simple truth, basic should be truth.
Thank you.
Okay, thank you for your attention.